Today we're going to be discussing care of patients with infectious respiratory problems. So our immunity concept that we'll be going over is the information around tuberculosis. What is tuberculosis? Tuberculosis is a common infectious disease caused by the bacterium Mycobacterium tuberculosis, M. tuberculosis. The bacteria usually affects the lungs, but it can also affect any part of the body. If TB is not treated properly, it can be fatal. So, the history of TB has been going on for a while, and here are some of the ads that the American Lung Association ad campaigns in order to prevent TB resurgence or help to curb the pandemic that was going on in the 1920s, 30s, 40s with TB. Some of them were comical, but it was very serious, of course. You can imagine going through a pandemic such as TB, just as we're going through this pandemic of COVID. Here are some more ads that they posted and put out warning people about the dangers of TB and how it spread. So TB is spread from person to person through the air via droplet nuclei. So TB can be expelled when an infectious person coughs, sneezes, speaks, or sings. And so you can get it, and transmission is accomplished when another person inhales that droplet nuclei. Let's go back one. So for TB, it is more common for people to be infected with the bacillus than develop active TB, actually. And that's primarily because the body's healthy immune system prevents the development of TB. The bacillus multiplies in the bronchi, and exudative response occurs and causes pneumonitis. Once you've acquired immunity to TB, its established growth of the bacillus is controlled, and that cell-mediated immunity develops within 2 to 10 weeks after infection. So that will equal a positive skin test. So there are several different ways that tuberculosis can deposit itself into the body. One of it is by a granulomatous inflammation created by the TB bacillus in the lung, and it's surrounded by collagen, fibroblasts, and lymphocytes. So that granulomatous inflammation actually encases the TB bacteria and prevents it from being transmitted throughout the rest of the body. Caseation necrosis is when necrotic tissue being turned into granular mass occurs in the center of the lesion. And if this area shows on the x-ray, it is the primary lesion. So once it's walled off, then actually what happens to the tissue that's walled off within that area where the TB is located at, it actually dies off. And that creates a crater looking like image on an x-ray, that primary or the center of the primary lesion. So here we're going to watch a video from the CDC about TB. It's about 2 minutes.
Tuberculosis, also known as TB, is spread through the air from one person to another. When someone with pulmonary TB disease coughs, TB bacteria are expelled into the air in tiny water droplets. These droplets can remain floating in the air for several hours, making it possible for someone nearby to inhale them. Once a person has breathed in droplets that contain TB bacteria, They travel down the trachea and enter the lungs, where they collect in the alveolar sacs. Once in the alveolar sacs, the bacteria begin to multiply. The body's immune system starts working and macrophages begin to surround the bacteria. A granuloma is formed to keep the bacteria from spreading. The TB bacteria remain in the lungs, but the body is protected from disease by the granuloma. In 8 to 10 weeks, the person will most likely test positive for latent TB infection. The progression from latent TB infection to TB disease occurs when the granuloma breaks open and the TB bacteria multiply. Then the person becomes sick with TB disease and may be infectious. This progression can occur immediately after infection, many years later, or not at all. When the TB escapes from the granuloma and begins destroying a person's lungs, it's called pulmonary TB. TB bacteria can also enter the bloodstream and travel to other parts of the body, causing extrapulmonary TB.
So there you have a video presentation of actually how TB enters the body and what the infectious material, uh, what effect it actually has on the body and tissues. So we'll continue with our slide presentation. So here's another ad campaign from the American Lung Association. Tuberculosis, find it, treat it, and conquer it. So before TB antibiotics, many patients were sent to sanatoriums. Drugs that kill TB bacteria were discovered in the 1940s and the 1950s that caused a decline in the death rates from TB during that time. So most TB sanatoriums were closed by the mid-1970s. So as you can see, TB has affected humans for millennia, for many, many years. So historically, it had been called names such as consumption, the wasting disease, the white plague, and for many, TB was a death sentence. So there was an increased incidence of TB in the mid-1980s, and some of the contributing factors for that was inadequate funding for TB control programs. Of course, during the mid-80s, that's when the HIV epidemic became insurgent upon humans at that time. So, and also there was an increased immigration from countries where TB is common. So then it was spread through homeless shelters and correctional facilities during the mid-1980s, and an increase in spread of multi-drug resistant TB also occurred. So that caused that significant increase during the mid-1980s. So tuberculosis then was commonly known as consumption, and some common treatments included fresh air, good nutrition, and sunlight. And then during that time, it killed 1 in 5 people from the 1600s to the 1800s. Now, it's commonly known as TB, tuberculosis, and is treated primarily by antibiotics. And the CDC reported 9,272 cases in 2016 in the United States. Some TB symptoms that you'll see common for your patients that are been diagnosed with TB or you suspect may have TB. They could have a bad cough that lasts 3 weeks or more, chest pain, weakness or fatigue, chills, a fever, weight loss, night sweats, and they can also be coughing up blood or sputum. Okay, so here's another pictographic representation of tuberculosis. So the patient will be experiencing progressive fatigue, malaise, or overall not feeling well, anorexia, weight loss. They're going to have a chronic cough, which will be productive. They're going to experience night sweat, hemoptysis, which is coughing up blood, and that's in the advanced state of TB. They're going to have pleural chest pain, that's chest pain in the pleural cavity of the chest. They're going to have a low grade temp, which will usually occur in the late afternoon. Treatment for TB involves TB medications that will be taken from 6 to 12 months. They'll need to decrease their activity to reserve their body's demand for oxygen. They're also going to be placed on respiratory isolation until they have a negative sputum, and then they're treated usually on an outpatient basis. Diagnosis for TB involves a TB skin test for that initial screening. Then next they will have a chest x-ray and then sputum studies. They need 3 specimens collected on different days. And in order for them to have a negative sputum or a negative diagnosis, or that the TB has successfully been treated, they will have to have 3 negative tests on those 3 different days. Again, here's the pathogenesis of the tuberculosis infection. So primary tuberculosis, you have that cell-mediated hypersensitivity response, that granulomatosis inflammatory response, then that GHON complex will be activated, and then the healed dormant lesion will form, and that dormant lesion will actually wall off the TB infection and prevent it from becoming active, and thus changing the diagnosis to active TB. So what can happen is that they have a secondary tuberculosis because of a reinfection, and then it can be progressive or disseminated tuberculosis. So instead of it being walled off into that healed dormant lesion, it will break open and be disseminated throughout the body. And that broke open lesion will be a reactivated tuberculosis infection. So they will have what's considered an active tuberculosis infection. So the immunity concept exemplar is our pulmonary tuberculosis. Pulmonary tuberculosis is highly communicable. And this is an uncommon type of TB, and it presents as pneumonia, and it's very, very infectious. Patients have a high fever and productive cough. It occurs most often in extremely young children and the elderly. It has also been seen in patients with immunosuppression, such as people with HIV/AIDS, and in patients in long-term corticosteroid therapy. So tuberculosis is the leading cause of death for people with HIV infection. So that's considered that secondary TB, and it's an increased incident for patients secondary to that HIV infection. So with the HIV infection, they have that immunosuppression, right? And then, like I said, it's the leading cause of death for people with HIV infection worldwide, and often then being testing positive for TB is the first manifestation of HIV infection. That extra pulmonary infection can cause an infection of the kidney, bone marrow, and other organs to also occur with HIV infected persons. Both persons with both HIV and TB usually have a more rapidly progressing form of TB and an increased viral load, which decreases the successful TB therapy, the success of TB therapy. So an increased number of other opportunistic infections, and then they also have an increased mortality rate. So because the patient, just to summarize, because the patient has an HIV infection, the HIV infection is actually suppressing their immune system enough, because of course it attacks those CD4 cells. And because those CD4 cells, are being attacked, then the body's immune system is rendered inactive or incompetent. So when TB comes along as an opportunistic infection, if they're around someone who has TB or they travel, then they are more susceptible to get TB. And because their immune system response is delayed or compromised because of the HIV infection, it causes the TB to just rapidly take over. And then once that happened, that along with the HIV virus infection is decreasing the CD4 T cell load and increasing the viral load for HIV and the bacterial load for TB. So TB and HIV, of course, TB is the leading cause of death worldwide for people infected with HIV. The epidemics drive and reinforce one another. So just as I was just explaining, HIV activates the dormant TB in a person who had already been infected, and it was walled off by the person's immune system. And so who then becomes infectious and able to spread the bacillus to others. So here is a pictograph of the spectrum of TB. So the infection can be eliminated with an innate immune response or with an acquired immune response. So it could go into the lungs, into the heart. The Mycobacterium tuberculosis is then in the body system. So here it is. They've inhaled it or got exposed to it. Then here it is. It makes its home there in the lungs. And then the body with a latent infection, the body actually walls off that TB infection and makes that granuloma there. And then, so in the event for a person with HIV, because they have a decreased immune system, then it can cause the TB, the Mycobacterium tuberculosis, to actually break through that wall and start affecting the body systemically. Okay. So here again, here's another pictograph to give you a better picture of it. Here's that latent infection. Then that cavitary tuberculosis is when it's actually the tissue has died off in that cavity. And then that's where you could see the pockets on the X-ray for TB. And this is the one where just that scar tissue is because the body has actually walled off TB. Then there's another kind of TB called miliary tuberculosis. So instead of having just one area where TB has attacked the lungs and the body has successfully walled it off, you'll have all these tiny lesions, these spots that you could see on the X-ray. So again, for persons are infected with the TB, but they do not have the disease, so they're not considered to have active TB. So that would be considered, let's go back to that slide just momentarily. So that is considered a latent infection. So the only sign of TB is that positive reaction in the tuberculosis skin test or the TB blood test. So the person with latent TB infection are not infectious and cannot spread TB infection to others because remember, it's walled off. So overall, without treatment, about 5 to 10% of infected persons will develop TB at some time in their lives. About half of those people who develop TB will do so within the first 2 years of infection. For persons whose immune systems are weak, especially the people with HIV infection, or that had the immunosuppression, or they were taking corticosteroids, those are one of the things that were on the list. They have the risk of developing TB disease. Their risk is considerably higher than for persons with normal immune systems. So, of special concern are persons infected by someone with extensively drug resistant TB who later develop TB disease. So, if someone already has been exposed to TB and their TB is considered drug resistant, and they later develop TB disease, those persons will have the extensively drug resistant TB, not the regular TB disease. So, a person with blatant TB infection, so of course, we're just going over that again. They have a skin test or blood test indicating a TB infection, has a normal chest x ray, and a negative sputum test, has TB bacteria in their body that are alive, but they're considered inactive, and they don't feel sick, and they cannot spread TB to others. They need treatment for latent TB infection to prevent the disease. However, if exposed and infected by a person with a multi-drug resistant TB or extensively drug resistant TB, preventative treatment may not be an option. So for that patient, we'll go back to that slide again. The patient with the latent infection, the danger for them is the TB can remain inactive, but if they're exposed to someone that have a drug resistant or extensively drug resistant form of TB, then they can acquire TB themselves. All right, so tuberculosis involves the upper lobes of the lung. This one, the cavitary tuberculosis, and it causes progressive lung destruction by forming cavities or enlarged air spaces within the lungs. That's that cavitary. So the cavitary TB involves those upper lobes of the lungs again, and it's causing that progressive lung destruction. And this can occur in a reactivation of the TB disease. And that happens in the upper lobes of the lung because that's where they are highly oxygenated. And that's an environment where the TB can actually thrive. So, for a patient experiencing cavitary tuberculosis, some of their symptoms can include that productive cough, night sweats, a fever, weight loss, weakness. They can have that coughing up blood, and they are highly contagious. And then it can actually spread into the pleural space that causes TB empyema. That's pus in the pleural fluid. And here's another form of TB, the miliary tuberculosis. What occurs with the miliary tuberculosis is caused by a sudden diffuse dissemination of tuberculobacilli through the bloodstream. And, miliary tuberculosis occurs mainly in children and young adults, but it can also occur in the older people. And it has a usually insidious onset with these age groups, or especially the older age groups. And this miliary tuberculosis is often known as cryptic tuberculosis because it's usually a slow, insidious onset. And then it's fatal when it's left without treatment, and death can occur within days or weeks. The patient becomes acutely ill with a high fever and is in danger of dying. The disease also may lead to a chronic illness and a slow decline. So, a patient with miliary tuberculosis, their initial chest x ray may be normal. So, patients who are immunosuppressed and children who have been exposed to the bacteria are at high risk for developing miliary TB. Again, here's just another pictogram for visual learners. I'm definitely a visual learner myself. I can remember pictures and then the words associated with the pictures often a lot better. So, tuberculosis transmission pathway, of course, here we go again. Pictogram depiction of how it's transmitted. The aerosols are in the air, the person inhales those aerosols. TB goes into the lungs, forms a lesion. The primary lesion becomes walled off, and it forms a scar that shows on the chest x ray. So that's 90 to 95% of infected individuals will have this. So then a secondary infection is a reaction of TB after immunosuppression, like HIV infection or even from smoking. So the cavities open into the bronchi, allowing the spread of TB through coughing. Right? So 5 to 10% of infected individuals actually experience this kind. And then it progresses once the cavities open, then it progresses into the system and causes that active TB disease. So for transmission, it matters on the infectiousness of the person with the TB disease, the environment where the exposure occurred, and their length of exposure. So, and then it also matters with the virulence or the strength of the tuberculi bacilli. And so, again, as we mentioned about that drug resistant TB, so that happens to um, speak on the strength of the TB. So, if the TB was regular TB, then whatever drugs that are usually um, prescribed to or antibiotics for bacteria can just kill it off. But if the patient is not consistent with taking the bacteria, the antibiotics, then the bacteria can become drug resistant. And then the length of exposure. Now, that happens to be of importance when we're dealing with the population, the homeless population, and people who live in jails, the ones that are incarcerated, because they're in such close quarters. So if there is someone in the pods that they live in the jail or in that area where the homeless seem to congregate, if someone has actually have TB, then they're exposed to that person constantly and constantly. So, or other people who have a different strand of TB. So that's how their transmission or their risk of transmission can increase. So, the best way to stop transmission is to isolate infectious persons and provide effective treatment to infectious persons as soon as possible. So, just like that ad from the American Lung Association, you have to identify TB, you got to find it, treat it treat it in order to conquer it. So let's move on to the next slide. So, a diagnostic assessment. So, for the NAA, which is your nucleic acid amplification, that test is the most accurate and it's rapid. A sputum culture actually confirms the diagnosis of TB2 as well. And then they have the PPD, which is the skin test that's given usually intradermally on the forearm. And the PPD stands for a purified protein derivative test. So there's actually a derivative of the TB that's given to them. And then if it the body recognizes it, then you'll see a reaction. And the reaction is in the form of an induration of 10 millimeters or greater in diameter, and that means that they have had a positive exposure to TB. Another way to diagnose or test for TB is through a blood analysis, and that's that quantiferon TB gold that's done, and a T-spot TB treatment, and the gene expert omni. So that's available for point of care testing. I know when I have recently got my TB shot or my TB screening done, they were requiring a series. So you get one done, 2 weeks later, you get another one done. I could never get back for the 2 weeks. So I actually had that quantiferon TB gold done so that it can definitively rule out that I have not been exposed to TB. So that's one way to get tested as well, especially working in the healthcare system. So the PPD skin test, a positive reaction does not mean that they have active TB disease. Again, they could have been exposed to it, but their body has walled it off. So they have a dormant form of TB. They were exposed to TB or they have the dormant TB disease. Now, there are certain people that are at risk for a TB infection. Again, as we mentioned, it'd be people in close contact with people infected with TB, and also for foreign born, that's the tongue twister, persons who come from another country where a TB can be prevalent. Also, people from low income groups and homeless people, individuals who live and or work in special settings, uh, healthcare workers who serve high risk groups, and some racial and ethnic minorities, again, because they come from a foreign country. And so, although they may have been born in the United States, their parents may have been born in a foreign country where there was a higher incidence of TB, so therefore they can be exposed to it. So racial and ethnic minorities, that's kind of how that can come into play as well. Infants, children, and adolescents, that they are at risk for TB infection. People who inject drugs and abuse drugs and or alcohol have an increased risk for a TB infection. So here's a pictographic representation about TB, how latent TB infection, the LTBI. The TB lives but doesn't grow in the body. It doesn't make the person feel sick or have any symptoms related to TB. They can't spread it from person to person, but it can advance to TB disease. So for that latent TB infection, they're going to have a TST or blood test is going to be positive. They will have that normal chest x-ray, and sometimes sputum smears and cultures will be negative. They have no symptom, no infectious uh, symptomology, and there is not a case of TB. Now, for the patient with active TB disease, so you see how the body walls off the TB bacilli. So active TB, it's growing in the body. The TB bacilli is no longer walled off and is actually entering into the tissues of the lungs. So the person is feeling sick. They do have symptoms, and TB is actively multiplying in the body. So their blood test or their TB skin test, the TST, will be positive. They're going to have that abnormal chest x ray. Their sputum smears and cultures may be positive, and they're going to have symptoms. They're going to have that cough, the fever, and the weight loss. And they're actually infective at this point. And this is considered a true case of TB. So for treatment, the person with active TB disease has a large amount of bacteria in the body. It can be treated by taking several drugs for 6 to 12 months. It is very important that people who have TB disease finish all of their medication. If the drugs are not taken correctly and consistently, the germs that are still alive may become resistant to those drugs. So, TB that is resistant to drugs is harder and more expensive to treat. So, in order to prevent that from happening, what usually happens when someone has a positive TB diagnosis, they're usually enrolled in these, what they call directly observed therapy. So, it's an internationally recommended strategy for TB control, and it's highly effective and highly efficient, and cost effective. And it comprises of 5 components because they have to have sustained political and financial commitment. So the policymakers have to be behind it to say that this and this has to happen in order to prevent a resurgence of a TB outbreak, to make sure that people are compliant with taking the medication properly. So diagnosis by a quality assured sputum smear microscopy. So not only are they going to have the TST or a chest x-ray, they're actually going to have that sputum smear done. And they're going to have standardized short course antibiotic treatment given under the direct and supportive observation. So what that means is they'll have to go to a location and actually be observed taking their medication. So a regular uninterrupted supply of high quality anti-TB drugs are given, and then they have standardized recording and reporting. So for patients that are participating in the DOTS, the annual cost for that patient is $3 to $7 for every healthy year of life that they're gaining. Because if someone has active TB, which is the actual TB disease, then of course you're looking at extensive hospitalizations and treatments to try to help that person stay alive and live a healthy life. So to make sure that they are able to stay alive and to have a healthy life, most people are placed in these DOTS programs to help to eradicate TB from their bodies. With our multi-drug resistant TB, again, it's caused by the M. tuberculosis organisms, and they're resistant to at least one TB treatment drug. So the common drugs that were used is this isoniazid, INH, rifampin, RIF, pyrazinamide, PZA, ethambutol, EMB. So those are the most commonly used anti-tuberculosis drugs. So resistant means that the drugs can no longer kill the bacteria. So again, we're going to go through these types of drug-resistant TB and what it means. So mono-resistant means that they're resistant to the first-line anti-TB drug only. So that first line of anti-TB drugs are these four: the INH, the RIF, the PZA, and the EMB. So polydrug resistance is they're resistant to more than one first-line drug other than both ionized and rifampicin. So they're resistant to the pyrazinamide and ethambutol. So they're resistant to these two. One of those more than one of those first line drugs so they can be resistant to both ionizing and rifampicin. Multi-drug resistant is their resistance to at least both ionizing and rifampicin. So they can be resistant to ionizin and ethambutol, and they're considered the polydrug resistance. Multi-drug resistance, they're resistant to both that ionizing and rifampicin. Rifampicin resistant is resistant to rifampicin is detected by using a phenotypic or genotypic methods, with or without resistance to other anti-TB drugs. It includes any resistance to rifampicin, whether mono-resistant, multi-drug resistant, polydrug resistant, or extensive drug resistant. So it's whatever drugs that they're resistant to. If rifampicin is in there, then they're considered rifampicin resistant. Extensive drug resistance, they're resistant to any fluoroquinolone and at least one of the 3 second line injectable drugs, in addition to multi-drug resistance. So there are other drugs that are used to treat TB other than the 4 first line drugs, and some of those are the fluoroquinolones and the myosin drugs. And we'll go over that a little bit more too. How does drug resistance happen? So the TB drugs are misused or mismanaged. Patients don't complete their full course of treatment. Healthcare providers prescribe the treatment, the wrong dose or the wrong length of time. And then the supplies of drugs is not available. And then also if the drugs are of poor quality. So that can increase the incidence of drug resistance to the TB drugs. So for interprofessional collaborative care, it involves assessment, which is noticing. So we want to get a good in-depth history of what the patient has been doing, where have they lived, do they come from another country and other than the United States, if they have a history of IV drug abuse, if they're having issues with alcohol abuse, if they've ever tested positive for HIV, and then we'll perform a physical assessment. So we want to notice whether they have issues with progressive fatigue, if they're complaining of lethargy, nausea, anorexia. If you weigh them, then they've been experiencing significant weight loss. Oh, I had that twice. If they're going to have irregular menses for our female patients, and a low-grade fever, along with night sweats, that cough, that mucopurulent sputum, and they have blood streaks in their sputum. So they have some of that hemoptysis going on. So for analysis, the part of the nursing process is interpreting TB. So they have a potential for an airway obstruction because of those thick secretions, and a weak cough because of the damage to the lung tissue. They have a potential for developing drug-resistant disease and spread the infection because they're not adhering to the drug therapy. They have a low drug therapy adherence. And then, two, they can experience anxiety related to their TB diagnosis and related to the persistent cough, as well as the fatigue that they could be experiencing, weight loss because of a decreased intake, and they're experiencing nausea from taking the anti-TB medications. Again, and that fatigue related to that poor gas exchange and increased energy demands from the lungs and from the body, demanding that oxygen. So part of our planning and implementation for the nursing process is actually responding. How are we going to respond to what we see? How are we going to respond to that assessment that we did, the physical assessment? How are we going to respond to the data collection from the patient's history? Well, one of the things that can help our patient is to promote that airway clearance. So one of the expected outcomes when we do that is we want to make sure they're going to have that patent airway. And a good sign of that is they're going to have an effective cough. So they're going to be able to cough and deep breathe and mobilize and expectorate those secretions. They're going to show evidence of adequate gas exchange when you're checking their pulse ox, right? Then you're actually not going to see any cyanosis. Their nail beds are going to be pink, no signs of blue, or their lips are not going to be blue. That means that they're having poor oxygenation. So some of the interventions that we could put in place for our patients is to encourage fluids. Of course, those enough fluids is going to help to liquefy those secretions and help to mobilize them so they won't be so viscous and thick and unable to be coughed up, because the fluids are going to help to thin and liquefy those secretions. Of course, as I mentioned, cough and deep breathing, that's what your CDB is. And then they can be encouraged to use an incentive spirometry, which will help with their diaphragmatic excursion, expanding that diaphragm, helping those lung tissues to expand and contract so they won't get tight and atrophy. So incentive spirometry is going to help exercise that diaphragm, exercise that lung tissue. Again, planning and implementation, responding. So we're going to assess them for decreasing the drug resistance and infection spread. We want to make sure they're free of active TB and not spreading it. And part of that will be to place them on a combination drug therapy and make sure they have strict adherence. That is the most effective way to help them to be free of TB, active TB, and not spread it. So here are the 4 common TB drugs that are used. So then again, here we come back to this negative sputum culture. That will mean that they are no longer infectious. They have to have 3 negative sputum cultures, and those cultures have to be taken on 3 different days, 3 consecutive different days. So again, with more responding, we want to manage their anxiety, and part of doing that is educating the patient about the disease. The more they know, the more they feel empowered, and they can make choices and be active participants in their care. So we want to hear them report of reduced anxiety, and we want to see a relaxed demeanor with our patients. And then when we're educating them, when they're relaxed and they're not experiencing any more anxiety, that enables them to listen and retain the information about how to better care for themselves and the importance of continuing with the drug therapy. So we need to work with them, identify some of the sources of anxiety, again, education, and then support. And because, as we mentioned before, most patients with TB, their treatment is on an outpatient basis. So we want to refer them to the proper programming where they can participate in the DOTS therapy. We want to work on improving their nutrition because they need, of course, nutrition to help their body, adequate nutrition to help their body to heal and fight TB along with the antibiotics. So we want their weight gain to improve, for them to gain weight and no longer be losing weight. And we want to have improved lab bios, especially those that test their nutritional status. We want to see them have increased energy and improved stamina, and then that they're making healthy choices as far as a balanced diet. And what we can do to help them with that is refer them to a nutritionist or conduct nutrition assessments. And also, along with that, we want to assess their teeth, whether they have teeth if any are missing, or their dentures if they're fitting properly, We want to assess how well they're keeping up on their oral hygiene, and then, of course, monitor their weight. And then we can assess the for substance abuse history as well, because, of course, if you're IV drug user, most of your time will be spent finding that next fix for the drugs. Or if you're an alcoholic, a lot of that time will be spent trying to find your next drink. So they're not thinking about food. That's one of the last things on their mind until they can, get that desire satiated for the drugs or the alcohol. And then because of the history of drug abuse or substance abuse, they're not eating, and then that can cause them to become nauseous if they are taking some of the medications for TB, or nauseous because of whatever the drugs are doing to their body. So they're not going to eat. So we have to assess them for the overall whole person, not just what we're seeing with the TB disease. We want to manage your fatigue. And some of the outcomes is that they're going to report increased energy, increased activity, and increased activity tolerance. Then also they'll be able to concentrate because they're resting and not overworking their body, and those demands for oxygen are not placed so heavily because they're able to manage their activities. So we want them to resume activity slowly, get lots of rest, and that their fatigue will improve as they progress with their drug therapy. And then it's really important for them to get a full night's rest and maybe even some naps during the day. So part of the home care management for a patient with TB would be to, excuse me, just got to catch up with myself. Part of the home care management would be to align them with a case manager or social services or some community health nursing agencies, because they need continued supervision for them to continue with their drug regimen to cure them of TB. Part of that has to do with self-management education. You need to educate them on what to expect from the direct observed therapy. And then also part of their healthcare resources, we want to make sure that they have follow-up care with their PCP for up to a year post-treatment. And then some referrals to AA if they happen to be experiencing addiction to alcohol or drugs, AA or ALA. ALA, the American Lung Association, has some very good tips for patients who are experiencing complications related to TB and how to care for themselves properly at home. And that is it for the information on TB. And here are some sites where I got some of that information. I would encourage you to, of course, listen to this presentation for the slide for TB, but also go through some of the handouts and the supplementary material. It would be a good idea, of course, to do your readings, listen to the PowerPoint video, watch the videos associated with the content, and then look at the supplementary material, as well as work on the case studies that will help to reinforce your learning. And repetition means retention, so that you could do an excellent job with the test on this information. If you have any questions, comments, or concerns, of course, email me, samantha.mccoy@rccc.edu.